Hello, I'm Dr. Donn Colby. Welcome to this session of the 2021 Bangkok HIV Symposium. This year, as of most conferences this year, we're doing virtual, unfortunately, but we do have a good panel of 4 presenters from the region who are going to talk to us about HIV prevention and care in the age of COVID, how it's affected their practice in terms of clinical and research practice on HIV, and then hopefully learn some lessons about how they've responded to those challenges in their local settings. So we have 4 presenters who are presenting today. And in this session, each presenter is going to give a brief overview of the situation in their country for about 5 minutes, and then we'll have a discussion at the end. So our first presentation today is Dr. Evy Yunihastuti from Indonesia. So Dr. Evy is on the Faculty of Medicine at Universitas Indonesia and in the Cipto Mangunkusumo Hospital in Jakarta. She did her medical degree, clinical training in internal medicine, PhD in HIV and co-infections, and a fellowship on allergy and clinical immunology at the University of Indonesia. She's worked on a number of clinical trials, including novel ART regimens and co-infections, such as hepatitis C and HPV. In addition to her clinical work, Dr. Evy is Vice President of the Indonesian Association of Physicians in HIV/AIDS Care, as a member of 2 expert panels at the Indonesia Ministry of Health on HIV and TB. So Dr. Evy, please go ahead with your presentation.
Thank you very much, Don. Good morning, everyone. I'm going to share the experience of for HIV prevention and care in the age of COVID, the Indonesian situation. As you might all aware that Indonesia is now the highest number of HIV COVID case in Southeast Asia. We have more than 700,000 confirmed cases yesterday, and 1,075 are in Jakarta, in the capital city of Indonesia. So because of the COVID, there are several hospitals appointed as the COVID-19 referral hospital, but the situation is most COVID referral hospitals are also HIV treatment centers. So in the hospital, we have to make a separate zones with the green, yellow, and red. Then the isolation room will be in the red area, and the one with the suspected of COVID will be directed there by the area. And another problem is that some of the HIV treatment centers are also COVID referral hospital that only accepting COVID-19 patient. That's make the HIV patient cannot go to that hospital anymore, and then they have to be referred to the local nearest center for HIV for their continuation. And of all the COVID-19 referral hospital, there is only a limited number of COVID centers that can provide birth delivery or surgery for the COVID-19 patient. Maybe there's only 4 to 5 of all of the hospital that can have a delivery. So if HIV infected patient get COVID, then everyone should be referred to only several centers for the delivery. That's what makes it difficult for the PMTCT program. Of course, with the COVID, we also had a personal resource issue because most of HIV physicians also treat COVID-19, and there's a regulation for all healthcare workers with comorbidity or the age above 55 years, they should work from home. And that what make more burden for the younger doctors, because we have to treat COVID patients and also maintaining other non-COVID patients in the hospital. And of course, some healthcare workers should undergo the isolation because they also contracted for COVID-19. That's what make the regular situation really change in the COVID area, era right now. So how about the HIV situation for during this COVID era. There is actually a drop number of new HIV cases in Indonesia, as we can see. Sorry, this is 2019. This is the new case of HIV in all over Indonesia. And then in September, there's only 32,000 new cases for HIV. But we don't see much different in the AIDS cases. Means that some people defer going to the hospital until they are very sick, and then they get diagnosed with HIV. So that's why there is an increased proportion of HIV/AIDS case, but low in HIV non-asymptomatic cases. However, for the HIV infected people, we don't see very much different in the outpatient visit. We can see the above one is for the all clinics. We can see in the April, there is a drop number of people visiting the hospital. This is for the diabetic cases or pulmonary cases. Then we see more and more patients who get have to go to the emergency room because they're stopping the drugs. But not for HIV patients, because we can see the number is dropped, but then it's still stable compared to other clinic. Because we know that the HIV patient need to get the drugs regularly. And what we have seen, there is many challenges and initiatives during the COVID era. We have to minimize patient contact in the health center. So in our clinic, we make a fast lane for the stable patients. So, and then they can get the drugs and meet the doctor first, and then go home as soon as possible. And then, of course, we have tried the telemedicine. However, for patients who are covered by the national insurance, mean they don't have to pay. Until now, telemedicine cannot be covered by national insurance. Only for the private clinic or for the private hospital, patient can use the telemedicine. But I think in 2021, the government make a new telemedicine regulation, and it could be possible for patients to get telemedicine and telecounseling consultation as part of their service. There are also many efforts to help with the drug delivery service, because some patients cannot go to the hospital, or they are stuck in somewhere, not in Jakarta near place. And Jakarta Health Agency with the Linkage Initiative actually start the Jack Antar and Jack Transporter to help delivering the drugs with the Gojek or Grab help with until their home. However, this is only happened in Jakarta. Other area in Indonesia, in other archipelago, they don't have this initiative. So many HIV center actually try to do many things with the help of the outreach people to help with the HIV patient to get their antiretroviral. In the hospital or the healthcare center, we also have to provide safer area for the consultations. We have more PPAs, and we provide triage nurse. If they think that the patient could have COVID, we have to refer to the red area, red zone. And then if not, then they can go to the clinic. And we have to make social distancing in the waiting room. And of course, the technical modification, because right now we cannot provide all rooms as a negative pressure room. So there are modifications. We have to put more exhaust fan, open the window, try to minimize the possibility of COVID contraction in the room, consultation room. And last times, we also give a special WhatsApp communication for all the information. So if the patient has problem, they can send us directly. However, it is not easy, because you cannot make a WhatsApp group for all patients, because they try to hide their identity, so they only want to talk with one person. So it's not like another disease because stigma is still there. And of course, the best thing for us is to know our patient situation. We understand that some patients are coming from the lower community, lower, and like 15 to 20% of them actually losing their job, and around more than 50% actually reducing their had decrease their income during the COVID area. So not everybody can use this communication. Not everybody actually have a phone that can be used with the WhatsApp or the line communication. So actually we learned that we have to know our own patient situation because not every case need to be treated the same way. Thank you.
Okay, thank you, Dr. Evy. So we're going to go to our next presenter, who's from Thailand. Professor Sasisopin Kiertiburanakul, and I'm sorry if my pronunciations are not correct on all of these names. But Professor Kiertiburanakul is a professor of medicine at the Faculty of Medicine Ramathibodi Hospital at Htin University in Bangkok. She served as the chief of the Division of Infectious Diseases since 2015. She is also assistant for the Dean of Corporate Communication, the Committee of the Royal College of Physicians of Thailand, and Secretary of the Infectious Disease Association of Thailand and the Thai AIDS Society. Professor Kiertiburanakul did her medical training and infectious diseases fellowship at the Faculty of Medicine Ramathibodi Hospital at Htin University. She obtained her Master of Health Science of Epidemiology from Johns Hopkins School of Public Health in the United States. And her research is focusing on general infectious diseases, opportunistic infections, and HIV. She's the author of more than 200 articles published in peer-reviewed medical journals. Okay, Professor Kiertiburanakul.
Thank you, Dr. Donn. Your pronunciation is perfect. So
Not perfect, but okay.
Okay. Good morning, everyone. So first of all, I would like to update the COVID data in Thailand. As of 28th of December, we have approximately 6,200 patients, confirmed patients, and the mortality rate is just only 1%. We have just only 60 deaths out of 6,000. But right now in December, during these 2 weeks, we are now in the new wave or the second wave of COVID-19 local transmission in Thailand. And just these 2 weeks, we have more than 2,000 cases. And most of the cases are migrant workers from Myanmar. And the epicenter of new outbreak was linked to the shrimp wholesale market in Samut Sakhon province, which is close to, very close to Bangkok. I would like to share you about my research. I and my colleague have an opportunity for doing research regarding impact of COVID-19 on HIV care. So I conduct my research in my hospital. I have almost 2,500 HIV infected patients in my hospital, but this is just only the 30 or 40% of the results. So we include 677 patients. These patients were interviewed by nurses via phone call. You can see the data here, approximately 60% were male, and the median age approximately 48, which range from 18 to 88 years. And more than 50% of the patients had followed up at my hospital more than 10 years. So we asked for the scoring, which is 1 is minimum and 5 is maximum. You can see that approximately 30% of the patients, which is a score 4 and 5, said that they had the COVID-19 impact on them and their families. And approximately 15% of the patients said score 4 and 5 said that COVID-19 impact on their psychosocial aspects such as insomnia, depressions, or anxieties. And approximately 30% of the case said that score 4 and 5 said that COVID-19 had impact on their economy. And overall 60% of the cases said that COVID-19 impact about HIV care. we have about 19% miss or postpone the appointment. But only 2% of the case has medication discontinuation, and 7% of the case have experience use telemedicine. In my hospital, we use the telemedicine system not for only for HIV patients, but also for the patients with other disease as well. The patients can contact us via telephone, also LINE application, which is special for HIV patients. So the patient can use LINE application, which is more commonly used than WhatsApp in Indonesia. We also have a list of the patients who missed the appointment, and we call them back whether they have enough medication. So the first step, the nurse will call the patient, ask about the history, and do the clinical assessment and confirm the address. And then the doctor will talk about history in detail, do the clinical assessments and prescribe medications. And after that, the pharmacist will arrange the medication according to the doctor prescriptions and forward the information to the cashier. And then the cashier checks the patient health insurance scheme and inform the patient to transfer the money to the hospital account. So if HIV patients in Thailand, they enroll to the National AIDS program, the drug is free. They pay just only $4 or $5 just for the management cost. On the next day, the parcel officer will pack the drug, and the package will deliver via express mail service on the next day after the financial approval. And if the patient stay in Bangkok, it takes just only 1 or 2 days for the package arrive. So, but if the patients live outside Bangkok, it takes about 3 to 4 days for the package. And after the patient receive the package, so they have to call back to confirm that they received the package, or they can use LINE official account to text us that they received the package. So this is just the overall briefly about the COVID-19 situation in Thailand and what do I manage HIV patient in my hospital. Thank you.
Okay, thank you for that update and overview. So we'll go on to our next presenter from Myanmar. Dr. Htin Aung Saw is the current professor of, president of Myanmar Medical Association and president of the Myanmar Society of HIV Medicine. He is former professor and head of the Department of Tropical and Infectious Diseases Department at the University of Medicine in Yangon. He has 31 years of experience in the government health services as a clinician in internal medicine and infectious diseases. Before retiring in 2016, he was in charge of the largest referral center for people living with HIV in Myanmar, was head of the HIV/AIDS Clinical Research Unit at the Department of Medical Research, and in 2005, he was the lead physician in starting the first public ART clinic in Myanmar. Dr. Saw is a member of the committee that writes the Myanmar National ART guidelines and also currently sits on the committees that advise the Myanmar Ministry of Health on COVID response and vaccine development. So please go ahead, Dr. Saw.
Thank you, Dr. Donn Colby, for your kind presentation, introduction, and for the organizers for inviting me to this panel. I will just talk a little bit about our experiences in Myanmar about this impact of COVID on HIV. This December, during the last annual review meeting of our National AIDS Program, reports show that COVID-19 had significant impacts on HIV services, especially in outreach prevention and HIV testing, clinic visits of facilities, linkage referral, and viral load testing. These were caused by not only by COVID itself, but by restrictions related to COVID, restrictions of movement, lockdown, interruption of transport and delays in arrival and shipments of reagents and medical products from international supplies. Especially the impact was mostly on outreach work. So HIV testing services were quite significantly affected. And you can see we had 2 waves, and even in the first wave in April, although there were not many cases, we had a significant impact on the testing services, and there were fewer people who were tested, were diagnosed, and who were entered into our treatment services. The estimate was that there were 20 to 30% fewer cases tested and detected than projected during that period. And that is only for our first wave data. We had even a bigger impact on during the second wave. In clinical care sites, for example, at one big hospital ERT service in Yangon, where on average 200 newly diagnosed HIV patients are seen each month. During the past 6 months, they were registering only about 100 new cases a month. So that is 50% fewer cases than we're seeing previously. You can see something like this in this report. That is a national data, but the impact was much, much bigger in Yangon. But this impact was less important in the retention of patients already in the treatment programs. This was because there was a contingency plan by the National AIDS Program, which was already in place for possible disruption of services caused by COVID-19, and it was implemented since April 2020. Some of the measures implemented included multi-month dispensing ERT, which resulted in up to 70% of HIV who are now receiving a 6-month supply of medicines. This plan also made possible provision of condoms, methadone easier, and were provided in larger amounts for longer periods, so clients did not need to come frequently to the facilities. But monitoring of patients was more or less more affected, you could say it. For example, for HIV viral testing, some 20 to 30% less people were tested than the previous years. Clinical consultations follow-ups also needed to follow social distancing, as my previous speakers had also mentioned, and infection prevention protocols had to be followed. These were very challenging for counseling in situations where there was a need to have a good person-to-person communication, building rapport with patients, and especially for key populations, vulnerable populations, and those who were newly diagnosed and who needed more attention. At the same time, PLHIV also found it very difficult to travel to care sites. Care providers, well, of course, adopted by switching on to teleconsultation, which again had its own strengths and weaknesses. We had a lot of teleconsultations. We used a lot of telecounseling. We trained a number of people, also through online training, and we, let's say, recruited mental health specialists to help us. But I personally remember one young person who was newly diagnosed as HIV positive while woke up for an STI and was referred to me recently. It was our first encounter. The young man was sitting in the front seat of his car with another person beside him in the driver's seat, thank God. We were on a video chat. I wasn't sure how to maintain confidentiality while explaining the lab results. I was not sure the person understood the weight of the situation and the follow-up plan. It was not really possible to maintain eye contact. There was no body language cues, and it was not an easy job at all. So it was a very challenging situation. Diagnosing associated infections in the respiratory tract, for example, like pulmonary tuberculosis, which are also quite common in our country, PCP, has also to be considered in the context of COVID, where many times we have to wait till we get the COVID lab results, and it could lead to possible delay in the management of these conditions. Associated challenges included barriers in assessing the student examinations, and protocols had to be revisited in how to handle respiratory samples. Gene expert might be easier, but direct smear, staining, and so on were much more difficult. So these were some of our challenges that we're seeing in our first wave, but as you can see in this slide, our second wave is even bigger. It has been going on since the middle of August, been growing throughout September, October, and December. Only since the last 2 weeks that we have been stabilizing our cases of COVID. So, but still, as been recently mentioned, that we had a spillover even to our neighboring countries, and Thailand is also seeing some of our cases migrating over there. So there are a lot of challenges we still have to face, but we're still trying to work on how to control and mitigate these impacts. Thank you for letting me join your presentation. Thank you.
Okay, thank you, Dr. Saw. So now we'll go ahead to our next and final presenter from Australia, Professor Sharon Lewin. She is the inaugural director of the Peter Doherty Institute for Infection and Immunity, a joint venture between the University of Melbourne and Royal Melbourne Hospital. She's an infectious disease physician and a basic scientist. She completed her medical degree and PhD in virology at Monash University and her postdoctoral fellowship with Dr. David Ho at Rockefeller University in 1999. So her research focuses on understanding why HIV persists, on treatment and developing clinical trials aimed at ultimately finding a cure for HIV infection, and she has over 300 publications. So Dr. Lewin, give it to you.
Thank you, Don, and pleasure to be with you all today. A shame we're not in Bangkok in January, which is always a wonderful time every year. I'd like to go, but not next year, unfortunately. So I thought I'd just briefly talk about COVID in Australia and the impact that COVID's had on treatment, prevention and research for HIV. So first of all, we've had a total of 28,000 cases in Australia, and majority of those came from a second wave of community transmission that only occurred in Melbourne. So in our first wave, we had about 8,000 cases that occurred across the country, and that led to about a 2-month lockdown and a change in practice across the country, which ended in about July. And then we had a second large wave of 20,000 cases in Melbourne that led to a very long lockdown just in Melbourne for about 11 weeks. It stopped now 60 days ago, I think. No, it stopped about 2 months ago, and we've had 60 days of no community transmission in Melbourne. And over the last 2 months, we've just had sporadic small outbreaks that are related to imported cases. Currently, there's one in Sydney with about 100 cases. So it's important to understand that, because HIV care has been affected differently across the country, because many parts of the country have had absolutely no COVID since that first wave in March and April. So in the first wave, pretty much everyone around the country moved to telehealth. And it was a very dramatic change, because not only did hospitals move to telehealth, but the government reimbursed all telehealth consultations. They'd never done that before. You had to see someone in person in order to bill. And pretty much overnight, they changed the billing arrangements. And I think that was quite incredible. Many practitioners report far better interaction of telehealth, or at least a mixture of telehealth and in-person consultations for everything that is, including HIV. And I think in Australia, telehealth will be here to stay, because there's now a mechanism to fund it. Directly in the area of HIV treatment, at least in Melbourne, all of our clinics moved to telehealth. I think I've seen one outpatient face-to-face in the last 10 months. Otherwise, everything's been online or by telephone. Pathology is collected locally, or patients will come into the hospital separately to have their pathology, and medications will be dispensed and either collected by the person in hospital or sent to their homes. And I think I don't really have a systematic assessment of the impact of that sort of care, but anecdotally, it seems to have been a very smooth transition. On the level of prevention, I'm not directly involved in PrEP programs, but there's been 2 large studies published on the impacts of COVID on PrEP in Australia, one in Melbourne and one in Sydney. In Melbourne, in the first lockdown, about 25% of people stopped taking PrEP, largely because they reported they'd stopped having casual sex. And similar numbers, but higher actually in Sydney, of 40% stopping daily PrEP. Interestingly, in Australia, on-demand PrEP is actually quite rare. Only about 5% of people, even though it's recommended in our guidelines, use on-demand PrEP. There was some shift from daily PrEP to on-demand PrEP in the large cohort in Melbourne, but only about 5%. Finally, research has had actually a disproportionately large impact, I think, given the numbers, the fact that we've really only had community transmission in that second wave in Melbourne, which is now over, and very limited COVID transmission in the rest of the country. effectively all clinical research stopped in that first wave. And certainly in Melbourne for our second wave, clinical research in areas such as treatment trials or cure trials, again, essentially stopped. And what we did in response to that was to develop some guidelines about how we could successfully do research in the era of COVID. And we basically based our approach on what had been done in San Francisco, and their approach is now published in Clinical Infectious Diseases. First author is Michael Peluso. And what we did was we first of all held a consultation with a large number of people living with HIV to assess how important it was that research continued during COVID, and the overwhelming view was it was very important and they wanted research to continue. And then we developed a range of strategies for risk mitigation for clinical research when COVID was above a certain incidence level. And we defined it based on what in Australia we call sustained community transmission, which is very, very low numbers. So if there's any evidence of community transmission, which was 10 cases over the last 3 days, then we would activate these interventions. And some of the risk mitigation strategies was reviewing enrolment criteria. So people that were at high risk of severe disease, obesity, pulmonary disease, diabetes, age, we could potentially consider modifying inclusion criteria. Inclusion of testing if people were undergoing a treatment interruption as part of their clinical research, which is quite common in cure studies. A review of whether the intervention could potentially make COVID worse, and an opportunity for people to have most of their visits through home visits rather than attending clinic in person. And this work, I'm actually part of a larger initiative run by the International AIDS Society currently, looking at how we can provide advice to people and communities around the world who are looking at doing research safely in the era of COVID. And we're just in the middle of that consultation. Denise Su is actually on the committee from Bangkok, and we're actually going to develop some consensus guidelines on how research can be safely performed in COVID. I guess a big hot issue at the moment around the world, less so in Australia, is how vaccine rollout will happen with people living with HIV. In the US, there's a very large advocacy effort to ensure that people with HIV get access to a COVID vaccine. In Australia, we won't have the COVID vaccine till March, but there's also discussion in our IS guidelines about whether participation in a research study, for example, should warrant receipt of a vaccine. So I think these are all important issues that are being discussed at the moment. And finally, I'll just end on a positive note of how COVID has impacted HIV research. And having worked in the cure area where we use interventions like antibodies or vaccines, I do think that the advances in COVID will accelerate work that we're doing in HIV. For example, RNA vaccines have been developed for HIV. We'll know so much more about RNA vaccines post-COVID. Broadly neutralizing antibodies, of course, being widely used in HIV, but now, at least in emergency use authorization for COVID antibodies. So I think some of the science that has been accelerated so quickly in COVID will have a positive impact on research for both a vaccine and cure for HIV. And I might stop there. Thanks, Don.
Thank you, Sharon, for that very nice update on what's going on in Australia. And thanks to all of our presenters for those updates. So now we have some time for discussion. I'll start out by asking a question. So one thing I noticed from all 4 presenters, you all brought up the same thing, which was telemedicine or telehealth. And it sounds like everybody's doing that. And we have quite a diversity in terms of settings, both culturally and socioeconomically, all the way from Australia to Myanmar. So what I might ask is each one of you in going to kind of a telehealth model, have you had any specific challenges in going from, before we just did everything in person and didn't even think about it, and now of course we have to think about it and try to do all the social distancing and going more to telehealth. So have you had any particular challenges in rolling out telehealth, and how have you addressed those challenges? So maybe we'll go around the same order we went before, so we can start with Dr. Evy.
Yeah, as I mentioned before, telemedicine 2020 is not covered by the government insurance. So the one who want to use telemedicine should pay by themselves. Yeah, the challenge is like some telemedicine required to be recorded. When we're talking about HIV and then talking to the patient with a sensitive issue, they are afraid that our discussion is being recorded. So yeah, that's one of the challenges.
Okay. Did you say that it's required to be recorded under the Indonesian law?
No. Actually, the law is not there at the moment. But in the beginning, there is a recommendation that it should be recorded, and then some patients reject that option. So we can use Zoom, or we can use a video call with the WhatsApp call or line call, but most patients actually prefer the WhatsApp call compared to Zoom with the recording version.
Okay, yeah, I can see how that would be a disincentive for people to do telemedicine if they think it's going to be recorded, and then issues of confidentiality, of course. Yeah. Okay, maybe we can go to Thailand and Professor Kiertiburanakul.
Okay. I think in my hostel we don't have any specific limitations. So I think most of the patients, they like telemedicine because they don't want to go to the hospital. Because if they come, they have to wait for a long queue to see a doctor. They have to wait for a long queue to get the medications. So I think they like to do a telemedicine. So they can use just a simple telephone, or they can use iPad if you want to see the face of each other. I think overall it's go through very well for telemedicine, and as I said, that if they enroll to national AIDS program, the drug is free. They just pay 100 baht or $3 or $4 US. That is for the mail. That's it.
Yeah.
But we have a problem at like the first wave around April and May about the stock of medications. So just most of the patients, they can get certainly 1 or 2 months because we have a limitation of the stock of the medication. But right now we can send out like 4 to 6 bottles if they want like 6 months.
Yeah. Maybe you said this in your presentation earlier, but in Thailand, does the NHSO, the health insurance, will it reimburse the doctor in the hospital for the televisits?
If the patient follow up at the regular visits, I don't get any money extra because I work regularly for the hospital.
Okay. No, but I was wondering that the hospital, then does the hospital get
they charge to just for the hospital? Yes.
Yeah. Okay, maybe we can go to Myanmar and Professor Saw.
Yes, thank you. So from my side, I think that there are certain challenges with this telemedicine. You know, we have been rushed into it, and we have not really thought about it and prepared in a sense. So one thing is that I'm trained as a clinician, so I always think about the quality of care. You know, and when we see patients personally, it's different than when we're consulting patients on the telephone or even with video chat. And I still feel that we're not giving a full or good, might not be giving a full good quality of care to the patients. As I said earlier about not having good eye contact or body language cues and things like that. And you know, that is one thing I would like to address. Second thing is that we don't have any real regulations or have not really thought about it. So there might be some difficulties in from both sides, as earlier said. Maybe there might be recordings which are not really allowed, and then we don't really know who's liable in a sense. Another thing is that, you know, there could be teleconsultation does not have any borders, right? So a person from one geographical region might be consulting a patient from another geographical region where he does not have a license to practice. I'm not sure how medical regulators or medical councils will react on that. And that is also something that I feel that, that has to be really thought of. And another thing, there are a lot of things that we have been talking about telemedicine, and also this data confidentiality, because in our country, we're using a lot of video chats, and you can send all these laboratory data and trials on the internet and send it to the, and these are a lot of confidential data, and still again, we don't have any regulation or rules on clearly stating how they should be handled. So yeah, these are my initial thoughts. Thank you.
Okay, thank you. Maybe we can go to Australia and Professor Lewin. And again, the question was, telemedicine, any specific sort of challenges and how you deal with them?
Yeah, I don't have a lot more to add. We certainly would not record any of our consultations, so I don't think that should be a barrier. Commonly use telephone rather than Zoom, but we wouldn't record any of those. As I mentioned earlier, the recognition by the government for payment has been a really big advance, and especially in a country like Australia, which is so large, so that people in rural communities that would normally, in a way, just what Dr. Saw was saying, would normally might have actually inferior access to specialist services. It's been greatly enhanced. You might live 3 or 4 hours drive from Melbourne. You would normally have to come in for the night. And you less easy to see specialists. So I think there's been some advantages for rural communities. We would normally dispense medicines for 6 months, so that's been an important advance. But I agree that that sort of subjective clinical acumen that you have when you meet with someone face to face, I don't think you could do it all online. And I think a hybrid model is probably the way of the future. We don't have a choice when there's a lot of COVID around, but post-COVID, I think we hopefully will see a hybrid model and not give it all up.
Yeah, thank you for that. And that kind of echoes what I hear from my colleagues in North America who have gone to mostly virtual meetings now, from probably all in person to almost all virtual now when they're doing patient encounters. I think the thought is here, and probably at least in the Western countries, that it will be a hybrid model in the future. There's some of the benefits to virtual medicine that people want to continue into the future. But and it sounds like that's maybe in Australia as well. But maybe I would just ask the other presenters too. What do you think? So a vaccine is coming. COVID is not over. We've probably got another 3, 6, 12 months before the pandemic is over, and enough people have been vaccinated that we can call the pandemic over. But what do you think in sort of Indonesia, Myanmar, and Thailand? After COVID is gone, you've had this telemedicine model. Do you think you can continue with telemedicine at some degree, or is it go back to all in person again?
Yeah, I think it's not for all patients actually, because some of the patients who use telemedicine then come to the hospital and say, "I'm boring, doctor. I want to meet you directly." Yeah. And yeah, we have to set up the regulation, like they can use telemedicine, and then like every 6 months we still have to do examination, because it's like the Professor Min say, seeing patient in the television is very different from seeing it by themselves. Especially for the new patient, you have to meet the patient directly. So there should be a regulation for the new patient, you have to meet them. And then for the long-term stable patient, maybe we still have to do examination every 6 months or 1 year, possibly.
Yeah, so it sounds like maybe a hybrid model as well. And as a clinician, I would also agree that first time, I think it's important to see the patient, because you get a lot of clues, I think, and a lot of communication by meeting someone in person that you're not going to get online. How about from Thailand? What do you think that the future is going to be?
Because my hospital is like the university hospital. We have a lot of patients, almost 7,000 OPD cases a day. So the policy of my hospital, they try to use more telemedicine after COVID, even not HIV, not for all other diseases as well. But I agree that for new cases or for the first year of the cases, I mean, for HIV, we need to see face-to-face, but after 1 year or 2 years or stable disease, so I think telemedicine is better, but at least it depends on, because we need to do blood tests. So how often that you accept, once a year, are you okay to do a blood test, or every 6 months? So if you want to do 6 months, so the patient have to come every 6 months. After that, you can send the medication. So in Thai guideline, we said every 6 months. But if some doctor, they say that once a year is enough, so it depends. So they come to see you just once a year. So I'm not sure about in Australia or other country, how often that you have to take blood check. So it depends on that.
Yeah, our guidelines are also 6 monthly CD4 count yearly, but what the option we have in Australia is that a patient can go to a local pathology to have their blood collected. They don't have to come into the hospital. And so there's share, and they don't have to pay. So there's a bit more integration between the private and public system, so that many patients don't need to come into the hospital to have their blood test done.
Yeah. So it sounds like too that maybe the HIV care is more specialized in the big cities, but so there's primary care offices everywhere. People get their blood tests and then do their specialist consultation online. So maybe I ask Professor Saw in Myanmar. I think you were the one who sort of brought up the most challenges with telemedicine. So what do you see as the future? Do you think you get rid of it, or are you going to keep it in some degree?
Well, no, I agree that telemedicine is going to stay. We have to, it's like COVID, we have to live with COVID. We have to find something called, the pandemic normal. And so, so we have the telemedicine also going to stay with us. And we have to find a sort of the best mixture of the two of things. I also agree that there will be a hybrid style of doing things. And of course, there will be challenging cases where we need to see the patients more in person, while there will be other conditions where we might have to just telephone consultation would be sufficient. So yes, but at the same time, I believe that we also have to develop better skills and caring for these patients, so that the telemedicine is not that easy. It's not just, you can just jump into telemedicine and go straight forward and keep on running. We have to to develop more skills. Yeah, that's my thoughts.
Okay, so my next question for the panelists is about research. So I know Sharon mentioned a little bit too about sort of research projects and how a lot of those sort of get pushed to the side during COVID because it's more sort of optional rather than necessary, as opposed to clinical medicine, which people got to get their medicine no matter what's going on. So we're going to ask our other presenters, because I know everybody is involved in both clinical activities and then HIV research as well, is if you've had any challenges in your HIV research, clinical research or prevention research, however you do it, any specific challenges related to COVID and how you've dealt with those.
Yes, of course, we have problem with the research because we have to skip some of the examination during the COVID. So we have to make some protocol adjustment for that. But there is also a challenge in doing the online research. Actually, there are many surveys online that we can do, and then we can have more and more patients outside the one area right now compared to the previous study. However, yeah, with the HIV, we have to know the respondent, because maybe like I told you, for the lower educations, they cannot use the online research platform. We have a study like comparing the COVID situation in autoimmune case. Like we can have like 100 respond in a week, but when we do it in HIV, there's only 35 in a week. So like because they don't know how to use the online platform and things like that, and like they don't want to pay for the internet for that research. Yeah, there's many challenges, but many opportunity that we can do.
Okay, thank you.
Yeah. For my situation, I think it is now it's not lockdown situation, so I don't have much problem about research. If the second wave is there's more cases in the second wave, so the government will announce the lockdown condition. So there's a limitation of the patient to come to the hospital. This is I think my just that concern, that issue, as that's only one issue.
Mm-hmm. Okay, Dr. Saw, any specific concerns about research or challenges in implementing research in Myanmar during COVID?
Yeah, I think that definitely COVID has been a boost on research for certain reasons. One thing is that people are more interested in research nowadays. People have more faith in scientific research and its results. So that's a good thing. And if you were to start a research work which was based on COVID, then there's a higher chance of getting funding for this research. So these are the good things. Our RRBs have been, let's say, adapting to the situations, and they are expediting a lot of their functions, and sometimes they can be even online. So these are the positive things. I also talk with researchers, and they say that bench workers have nowadays are collaborating more with field workers. So these are the good things. The barriers are that field workers cannot really go into the field, with the travel restrictions. In our country, it's the COVID is quite a large. Unfortunately, we have a big number of cases, so we still have a lot of travel restrictions. And as I said, the biological sampling, handling, and things like that are still a bit difficult. So those are the pros and cons that I see at the moment. And maybe one other thing I would like to add is that obtaining consent from the participants, since we cannot really go and see these patients in person, we're trying to find out a way that we can get electronic consent from these people. But then again, as discussed earlier, it's not for everybody. So I don't know how it will impact on the bias of population studies and things like that. Yeah, it's some of my thoughts.
Okay, thank you. So we just have a few minutes left in this session. So I was going to ask one last question for each of the presenters. If you have any final recommendations or words of advice for our colleagues in the region in terms of implementing HIV care, prevention, research projects during the time of COVID. So maybe we can start with Dr. Evy again.
Yeah, my point is we have to communicate more and know the situations because everyone may have a different situations, and like you have to open yourself. Like they can contact us anytime. Like in the past 2 weeks, I get more and more texts from patients that show, doctor, now I am COVID positive. What should I do? Because we have to be able to guide them through this pandemic. When they get sick, not everyone can be treated in our hospital. They might go everywhere, and they need good recommendation from us, what to do, what to expect. And we have to open ourselves, and of course keep healthy, because if we get sick, then we cannot do many things. You have to stop for a while.
Hey, maybe go to Thailand.
For me?
Yes. Please.
Okay. Yeah. I think I agree that the first thing we need to give the knowledge to our HIV infected patients. So as I have information in my hospital, I have 2,500 patients, but just only one HIV patient confirmed COVID-19 infection. So it's very, very low risk for HIV infection. So I would like to say that if you are HIV, you have an equal risk to get infections. But we have to do the prevention as others, I think just the education for the patients is important.
Okay, and let's go to Professor Saw.
Yes, thank you. So about COVID on HIV, I think from the scientific side, maybe Dr. Sharon Lewin will be much more expert than me to talk about it. But from the public health side, you know, as I mentioned earlier, prevention has been really, preventive, you know, work has been more or less been impeded because of all the restrictions and things like that. So we have to be careful about that. Although there are systems that have been in place to for the retention of the people that are already in the treatment care system. So that is one thing. As for the research, I think that nowadays, you know, at least in our country, there have been a lot of medical conferences that have been postponed because of the COVID pandemic, and this has had a negative impact on young researchers to present their papers and so on. So we are now also adapting on virtual conferences and meetings and paper reading opportunities. And our Myanmar Medical Association itself is going to conduct our medical conference next month virtually. So I think things like that should be created more to make an conducive environment for researchers. Yeah, these are my thoughts. Thank you.
Okay, thank you. And then, so Sharon, we'll go to you for the final thoughts.
Well, I think just final thoughts on research in the era of COVID. I think I talk about the community, people living with HIV, and researchers. So I think it's really important that each of us speak to our community of people living with HIV and hear from them how important research is, because that will also mean that we don't stop the fight to make sure that research continues, and that together we can develop sort of these risk mitigation plans of clear stepwise approaches to how you might do research, rather than just saying it's all too hard. And I think we could say that in 2020 because there was all this uncertainty. We didn't really know where it was going to go, and some decisions weren't made. But 2021, COVID's going to be around for a while. We're going to be facing the challenge of vaccine rollout, which will be variable across the world. And so I think we have to make a really proactive effort to continue research in this uncertain environment. And finally, just building on what Dr. Saw said, that same uncertainty exists for professional development. Many of us put things on hold because we thought, oh, well, you know, 2020 is uncertain. I know personally that the conferences I attended, I tried doing, you know, an hour call, and at 11 p.m. at night, I didn't take time off work to actually attend a conference properly. But I'm going to do it differently in 2021, because I think in 2020, I put a lot of stuff on hold thinking we're just going to get to the end of the year. But professional development is really important. Having a few days away from your busy work life to immerse yourself into new knowledge is really important. And we've got to just do it differently when we're sitting in our lounge rooms. And I'm going to try and do it differently this year, because we're no longer sort of running a race. It's like a marathon, and so we've just got to keep going for that long distance. And professional development's a big part of it, including opportunities for younger researchers to present their work, etc. So I think if I could provide advice to any of the doctors and clinicians and researchers out there, take time out over 2021 and make sure you pay attention to professional development. It's really important.
Hey, thank you. And I would agree with that. Professional development, both for ourselves and for our younger colleagues coming up. So with that, we're at the end of our session. So I would like to thank each of our four presenters for presenting virtually in a challenging environment for the Bangkok Symposium this year. Thanks to the organizers at HIV-NAT and the Thai Red Cross for organizing the conference again. And then hopefully we'll see you all in Bangkok next year under different and better circumstances than this year. So thank you all.
Thank you.
Yeah. Thanks,
Donn.
Okay, thanks
See you later.
everyone. Thanks everyone.
Bye.
Bye.
Bye.